We've covered the acute fire of pericarditis and the rapid mechanical disaster of tamponade. Now we move to part 4, which is the chronic, insidious consequence, constrictive pericarditis. This is where the simple inflammation leads to permanent, relentless restriction.
Chronic constrictive pericarditis is a different beast entirely. It's the result of the acute inflammation healing via dense fibrosis. The pericardial cavity itself is obliterated, and the resulting scar tissue is firm, tough, and often calcified, encasing the heart in what amounts to a rigid, unyielding suit of armor.
So if tamponade is like squeezing a sponge underwater, constriction is like trying to squeeze a heart that's already encased in cement.
That's a great analogy. The fundamental physiological problem is that the rigid pericardium imposes a fixed volume limit on the heart, restricting ventricular filling. But this is the core difference from tamponade. In constriction, filling is actually unimpeded during the very early phase of diastole.
Okay.
But it is then abruptly and immediately halted when the ventricles expand to meet that rigid scar.
The moment the heart hits that rigid wall, filling just stops dead.
Exactly. And this causes a very specific pressure waveform that we can see. As for etiology, constriction can follow any acute episode, viral, post-surgical, traumatic, or from a purulent infection. But again, we have to emphasize mediastinal irradiation, often used years prior for cancer treatment, and tuberculosis, which is a major global cause of this chronic scarring.
Because the ventricles can't fill forward, the blood backs up systemically. How do these patients present clinically?
They present with symptoms of chronic systemic venous congestion that can mimic severe heart failure or, disturbingly, advanced liver disease. They complain of extreme weakness and fatigue, weight gain from fluid retention, and increased abdominal girth due to massive ascites.
You mentioned the cirrhosis mimic earlier. How serious is that misdiagnosis risk?
It is a critical diagnostic trap. The pressure backup causes severe congestion of the liver, what we call congestive hypotomagoe, which can be so pronounced it actually causes jaundice, the yellowing of the skin and eyes.
And the ascites?
Because the ascites, the fluid in the abdomen, is often more prominent than the swelling in the legs, the entire clinical picture can scream hepatic cirrhosis. The key, once again, is to look at the neck veins.
What are the neck veins telling us in constriction?
They are distended, showing high central venous pressure, and they exhibit a highly characteristic sign called Kussmaul sign. Normally, when you inhale, the JVP drops. In constriction, that rigid pericardium is so restrictive that the increased blood return from inspiration cannot be accommodated by the right heart.
So the pressure goes up.
The jugular venous pressure paradoxically fails to decline or can even rise during inspiration. Finding Kussmaul sign is highly suggestive of chronic constriction.
And what sound does this rigid stop create?
The pericardial knock. Because early ventricular filling is rapid, but then it slams into that rigid, unyielding pericardial casing, it creates this loud, conspicuous early third heart sound, the knock. It's louder, earlier, and sharper than a typical S3 gallop, and is highly indicative of this process.
Let's revisit the hemodynamics and those atrial pressure pulses we discussed with tamponade. How does the constriction pattern differ in the venous pulse?
The similarity is the pressure equalization. The end diastolic pressures in all 4 chambers are elevated and basically equal, usually within about 5 millimilli of each other. The difference lies entirely in that diastolic filling phase and therefore in the Y descent.
Okay.
In constriction, the atrial pressure pulses show an M-shaped contour with prominent X and Y descents.
Wait, so why is the Y descent suddenly prominent again when it was totally absent in tamponade?
Remember that in constriction, early diastolic filling is unimpeded for a brief moment until the heart hits the scar tissue. That rapid, unimpeded early filling causes a swift drop in atrial pressure, which translates into a prominent Y descent on the tracing.
So that one detail absent I descent in tamponade, prominent Y descent in constriction, is essential for bedside differentiation.
It is a critical clue.
What about the ECG? Is there an electrical signature to this chronic scar?
It's less dramatic than the acute inflammation or the swinging heart of tamponade. We typically see low voltage in the QRS complexes and just diffuse, nonspecific flattening or inversion of the T waves. Atrial fibrillation is common, affecting about a third of patients, but crucially, there is no electrical alternans because the heart is firmly fixed and cannot swing freely.
How do we image this constriction? X-rays might show calcification, but you said that's not enough.
Right, a chest X-ray showing pericardial calcification is common, and it definitely raises suspicion, but about a third of constriction cases have no visible calcification at all. Echocardiography can show the pericardial thickening and the rapid flattening of the LV posterior wall and diastole.
But for a definitive structural diagnosis.
For that, CT or MRI are superior. These modalities can accurately detect and measure the pericardial thickening and enhancement, which is the physical evidence of the scar tissue itself.
But the functional gold standard still comes down to flow dynamics, right?
Yes. Doppler echocardiography provides the decisive functional data. It reveals an exaggerated respiratory variation in transvalvular flow velocity. We see that the velocity of blood flow across the mitral valve on the left side decreases significantly during inspiration. Meanwhile, the flow across the tricuspid valve on the right side increases during inspiration.
And this pattern reflects that extreme ventricular interdependence caused by the rigid constraint.
Exactly. The fixed, rigid sac makes the chambers compete intensely for space during the respiratory cycle, creating that dramatic, highly specific flow variation. This is the crucial finding that helps us distinguish constriction from other conditions that cause filling restriction.
Since this is a physical constraint, surgery is really the only answer.
Pericardiectomy, or surgical resection of the scarred constrictive pericardium, is the sole definitive treatment. The operation has to be meticulously complete, removing both the parietal and often the visceral pericardium as well.
What are the risks?
The surgical risk is not insignificant, around 5 to 10% operative mortality. And it is highest in patients with very advanced disease or in those whose constriction is due to previous radiation therapy, because that tissue is very fragile.
So if we catch it early, the patient has a much better outcome.
Precisely. Early diagnosis and intervention are critical to prevent prolonged systemic congestion, which can lead to irreversible liver and kidney damage, and to ensure the heart muscle hasn't developed secondary scarring. Recovery is often progressive, with the clinical benefit accumulating over months after the surgery.
We've established the 3 primary pathological forms. In Part 5, we have to synthesize this information by looking at the confusing overlap syndromes and, most importantly, the crucial differential diagnosis that separates the curable from the non-curable.
Let's start with that hybrid scenario, effusive constrictive pericarditis. This is a subacute condition that combines a tense fluid effusion and underlying constriction caused by a thickened, unyielding visceral pericardium. The patient presents with classic signs of tamponade because of the fluid pressure.
So how do you uncover the underlying constriction that's hiding beneath all that fluid?
This is a textbook example of diagnosis during therapy. When the clinician performs pericardiocentesis and drains the tense fluid, the central venous pressure will drop, but critically, it will not return to normal levels. Once the pressure from the fluid is gone, the underlying rigid visceral pericardium takes over, and the patient's hemodynamic profile instantly switches from one of tamponade to one of clear constriction.
The diagnosis is literally made when you realize the procedure didn't fully solve the problem.
It's the physiological clue that reveals the double pathology. And because both the fluid and the scar are limiting the heart, the treatment has to be aggressive. Wide surgical excision of both the visceral and parietal pericardium is usually necessary.
Let's circle back to tuberculous pericardial disease, as its management plan is unique because of the chronic infectious nature.
TB pericarditis is extremely insidious. It's a major cause of chronic effusion and constriction globally. If a patient presents with an obscure, chronic, high-protein effusion, especially if they are in an endemic area or are immunocompromised, TB has to be at the top of the list.
And since you can't wait weeks for a culture, how do we confirm this diagnosis rapidly?
We use advanced techniques. Diagnosis is often confirmed by finding Mycobacterium tuberculosis DNA using PCR on the fluid, or by identifying markedly elevated levels of adeninase deaminase in the pericardial fluid. If needed, a pericardial biopsy can confirm the presence of the characteristic granulomas with caseation.
And what's the combined approach for treatment then?
Once confirmed, the patient is started immediately on prolonged antituberculous chemotherapy, typically for many months. Critically, though, surgery is often prophylactic here. If a biopsy shows pericardial thickening, even if the patient isn't fully constrictive yet, pericardiectomy is often performed after just 2 to 4 weeks of chemotherapy,
To prevent it from getting worse.
to prevent the development of permanent irreversible constriction later on.
Now, for the most essential diagnostic imperative for our listeners, the difference between constrictive pericarditis and restrictive cardiomyopathy, or RCM. Why is this distinction so life and death?
This is the moment where clinical precision is paramount. Both conditions severely restrict ventricular filling, leading to identical symptoms of systemic venous congestion, the ascites, the JVD, the fatigue, and they both show equalization of end diastolic pressures.
So they look the same on the surface.
They do, but RCM is a disease of the heart muscle itself where the myocardium is stiff and non-compliant. Constrictive pericarditis is a disease of the external sac.
And the distinction matters entirely because constriction is potentially surgically curable and RCM is generally not.
Exactly. Misdiagnosing a surgically correctable constriction as an untreatable RCM is a massive failure. We need a mental checklist based on the specific physical and functional signs we've been discussing.
Okay, let's build that checklist. What are the tells for constriction?
We look for signs that the external mechanical constraint is dictating the function.
Yeah.
First, Kussmaul sign, the JVP rising on inspiration, is typically present in constriction and generally absent in RCM.
Got it.
Second, the pericardial knock is heard only in constriction. Third, on hemodynamics, constriction shows that highly characteristic prominent Y descent in the atrial pulse. Fourth, imaging, like a CT or MRI, will reveal definitive pericardial thickening or calcification.
So if the patient has all the symptoms of chronic heart failure, but none of those telltale pericardial signs,
Then we have to shift our focus to RCM. RCM typically lacks Kussmaul sign, lacks the pericardial knock, and the imaging shows a normal pericardial thickness. The problem is internal. Finally, the flow dynamics are the ultimate test. Only constriction exhibits that dramatic, exaggerated respiratory variation in mitral and tricuspid flow velocities that you see on Doppler echo. That variation is the definitive proof of external compression forcing ventricular interdependence.
it sounds like the entire diagnostic journey is about ruling out the heart muscle disease by proving the presence of the external restrictive casing.
It is a diagnostic hunt that requires using the most sophisticated tools, Doppler and high-resolution imaging, to interpret the physiological chaos caused by a tiny scarred sac. Other rarer conditions, like a severe ventricular myocardial infarction, cor pulmonale, or tricuspid stenosis, can also mimic venous congestion, but they all ultimately lack those specific, unmistakable mechanical and electrical signatures of pericardial disease.
So to wrap this up, what we've really navigated today is the crucial relationship between structure and function.